Welcome, everybody. We're so excited to have you joining us here for the second of this four-part deep dive into the radar implementation, strength assessment, and quality of care tools. Last week, we had the opportunity to talk about intrapartum care. This week, we're talking about family planning, a topic that many of you indicated a lot of interest in wanting to know more about. So I think this discussion is going to be a particularly exciting one. For those of you who I haven't met yet, my name is Jessica Ferne. I am the Director of Global Health Impact here at CanWaCH, the Canadian Partnership for Women and Children's Health. And it is my pleasure to continue to work with our amazing colleagues at Johns Hopkins University on the radar team. We've had lots of great time together, and I know that this is going to be a fantastic discussion. With that, let me pass it over to, I believe, our colleague Diwakar from Johns Hopkins University to get us started. Diwakar, over to you.
Hello, and good morning to all of you. Some of you have may have met me last week when I did the intrapartum care session 2. For others, I just wanted to quickly introduce myself and our team from Johns Hopkins. My name is Diwakar Mohan. I'm an assistant scientist and faculty at the School of Public Health at Johns Hopkins University. I primarily work on the radar project as the lead, along with Melissa, Elizabeth, and Emily for implementation strength and quality of care.
Hi, I'm Melissa Marx. I'm an assistant professor, and I am one of the leads of the ISA QOC team at the Johns Hopkins School of Public Health. And I'm an epidemiologist by training and have been working with this team on evaluating maternal child health programs for the past 5 years.
Emily?
Hi everyone, my name is Emily Frost. I'm a research associate with this team at Hopkins. My background is in maternal and child health programming.
Cynthia?
Hi everyone, I'm now a second-year student assistant in this team. My major is social and behavioral interventions. I'm happy to join this meeting. Thank you.
And Elizabeth?
Thanks so much. My name is Elizabeth Hazel. I'm also at Johns Hopkins. I'm an assistant scientist. I've been involved with radar off and on for the past 5 years as well, but I was most involved with the family planning implementation of the radar tools.
Thank you. So I'm going to quickly go down the list of participants, and just to please give us your name, your organization, and give us a short blurb of your experience either with QOC, ISA QOC studies or program strengthening in the area or M&E and measurement. So just give us a brief introduction of who you are so that we can engage with you better. And do let us know what your expectations and plans are for the radar suite of tools.
Yeah, hi everyone. My name's Naila, and I work as a consultant on the technical review panel with the Amplify Change, which is a organization that delivers funding to various countries across the world. And yes, I've previously also worked on reproductive health issues and monitoring and evaluation with UNFPA, Save the Children, Asia Foundation. And, you know, some of the I find the radar tools very interesting because, you know, I'm basically from Pakistan, and we've used the Kielman model to evaluate the district health system, and some of the tools which are being used to evaluate the reproductive health component, you know, or EMNC, you know, I've kind of used those through the Kielman model. So yeah, it's very interesting, and I'm really learning a lot from it. And thank you for the opportunity.
Thanks, Naila. Tamrat?
Hi, I'm Tamrat from World Vision Canada. I'm an Intensive Evaluation Specialist, and I'm looking forward to learn new things. We've been using SARA tools so far on this area of measurement, and hope that we would learn new things on what you're working on the radar tools, especially on quality of care area. Thanks.
Okay. Thank you. Vaishnavi?
I'm Vaishnavi. I also go by V for short. So I am the M&E officer for SRHR project. We operate in 4 of the East African countries, and we also have a small advocacy part in Canada also. So in terms of radar, well, I got introduced to it at the last webinar that CanWaCH had organized, and it actually comes at a perfect time because I was in the process of thinking of developing a tool for more monitoring our work along with evaluation of our work in the health systems that we're trying to make a change in. So it works out perfectly. And in terms of what I want out of it is, obviously I want to learn more about the tools, but also design or take it and modify it to match my needs for the projects and move forward with like implementation so that we can monitor my project as soon as possible. So yeah, hi to everybody.
Thank you. Thank you to all of you. I hope I haven't left out anybody. If in case, please do chime in. So let me start the process by quickly walking through what are our objectives for today. So one of the key objectives that we have, that we are looking at, is to provide an orientation to all of you about the radar tools, specifically the implementation strength and quality of care assessment tools, and all the supporting documents and all the various little things that go with these tools. And one of the key things that we want to do is get your feedback on these tools. We want to foster discussion. We want to ask you for honest feedback, and we want to incorporate some of your thoughts and suggestions into the next round of tools. So it would be important for you to provide us your feedback, and we want this to be a nice interactive two-way session. And we also want to make sure that we provide you these key instructions on how to access the tool package, and if you want, you can give us more inputs about these tools even after the webinar is over. So these are kind of our 3 important objectives for this entire session. I'll now hand over to Elizabeth, who will run today's session for family planning. Elizabeth.
Yeah, thank you so much. I think we're going to start by having Melissa do a brief introduction to the radar, the tools, and the package. And then we'll go into more of an overview of the tools and then an in-depth discussion. So Melissa, if you're ready, please go ahead.
I'm ready. Let's see, I'm looking, oh great. Thank you so much. And apologies if some of you have seen this before. We like to give a little brief reminder of what radar is and where we fit in the impact model for those who haven't participated with us before. I promise it's only a few minutes. So radar is a project that the Canadian government funded Johns Hopkins for, so that we could develop and test out tools that could be made widely available for people to use, so that people were thinking about common methods and common indicators, and so data could be viewed across programs to see how programs are doing and what their effect is on populations. And our little slice of this is implementation, strength, and quality of care. We've done implementations where we test out our tools, but also generate true, real evaluations that can guide programs to improve and drive policy recommendations. In Malawi, and we'll talk about that today, in Mali, and Louis was a part of this, as he said. He was the lead from the CRC side. In Mozambique, and Clarissa is on, and she was a part of that, and also in Mali. And these were all on different kinds of programs, and today we'll be focusing on Malawi, where we did family planning with a little bit of a focus on youth-friendly family planning. This project was done in collaboration with the Malawian government, both the statistics office, and with a contractor, and Elizabeth will talk about that in more detail. And it was done across all districts of Malawi. Next slide. So the goals of implementation, strength, and quality of care evaluations are to identify strengths and gaps to inform improvements in program implementation and policy. This is one reason why we hear from lots of NGOs that these tools are very useful for them. It also helps us to understand whether a program can provide care at a level high enough to impact health. It is not, we are not measuring impact, we are not measuring coverage, but we're trying to figure out if the dose of the program and the way it's rolled out are strong enough to impact health. So, and finally, it is as a part of a larger evaluation strategy, it's a way in combination with coverage surveys and either impact measurement or impact estimation to explain why a program did or did not have an impact on health outcomes. So it strengthens your causal reasoning around your causal inference around whether your program may have been a contributing factor to an increase in coverage and impact. Next slide. So you may have heard me say this and others say this before, but we are thinking, when we talk about quality of care and implementation strength, we're talking about quality of care focused a bit on technical quality, which we think of as a degree to which health services increase the likelihood of desired health outcomes. Sorry, you lost me for a second there, and are consistent with current professional knowledge. Next slide, please. And this term may be less familiar to those of you who haven't interacted with the radar tools before. Implementation strength. We think about implementation strength as the readiness to deliver services. If you're familiar with Donna Benian's framework, part of implementation strength is structural quality. We think of it as the dose of services available. And I'm not going to read through this, these boxes at the bottom, but components or domains of implementation strength are accessibility, availability, infrastructure, personnel, and commodities. Next slide. So just to put this into perspective, almost all of you, if not all of you, have seen Radar's impact model. All of you have created your own impact models. In our parlance, impact is what the Canadian government considers ultimate outcome. Can you click? So when we think about our program, we put it into our impact model. And then when we think about our evaluation, we think about the questions that we want to ask and answer across the impact model to understand if our program is working. Click one more time, please. And, oops, oh, I'm sorry, there's one more animation there. Go back. So we are really focusing on activities and outputs. Really, the question 2 and question 3 here. If you participated in the coverage survey workshops, you were looking at question 4. If you participated in any of the list workshops, you talked about question 5 and perhaps question 1, which is you can also get out of the list. But for our implementation strength and quality of care, we're really talking about questions 1 and 2. Next slide. So in deciding which radar tools to use, we have lots of that we've used that you'll hear about, and Elizabeth will go through them quite granularly. We use provider interviews and assessments of supplies, equipment, and service. A lot of that is similar to what Acera or Acera uses. I think somebody said that they use SARAs or SPAs. And we also use, to measure provider technical performance, we use direct observation, record reviews, simulated client, health worker test or vignette, and patient exit interview. And so some people do ask what to consider when they're thinking about which tool to use. And we recommend, before you even look at the tools, ensuring that you are clear and you are in agreement with whoever's paying for it, what it is you are trying to do. Are you looking at all three of those goals that I mentioned, policy, program, and evaluation strengthening? And you want to know and articulate what specific questions you're trying to answer? And you want to try to determine the implications of getting it right or wrong. Is it life or death? If so, it needs to be done more carefully. You need to understand your funding and resource limitations, or your plethora of funding and resources, and the feasibility of doing your data collection using these different methods, given those constraints or the availability of those funds. So I just wanted to start us out with that, and I'm going to hand it over to Elizabeth to handle some questions about radar. And this is just setting up for the rest of the time we're together. We'll be talking about the family planning methods and tools specifically.
All right, thank you so much. Any questions about the radar project overall, but before we get going into the family planning tools? All right, again, if you have any questions during the presentation, feel free to interrupt me, just unmute yourself and talk. If you're having trouble unmuting or don't want to do that for whatever reason, you can just put it in the chat box, and I think someone's monitoring that to take questions as well. So, all right, so we'll start here. I created this method summary slide of the family planning implementation strength assessment and quality of care tools that we looked at. So starting with the in-charge interviews, which you also may know as facility audits, provider interviews that collect information on provider demographics, provider knowledge. These also include clinical vignettes to test provider knowledge, a simulated client, tool and protocol, a direct observation, and client exit interviews. So when you're considering the feasibility and what you want to measure, we kind of put together this summary slide to help us and to help you consider which would be most appropriate for your context. So if you're interested in readiness, of course, you'd want to look at the in-charge interviews or the facility audits, which collect information on commodities, training, and supervision at the facility level. Also, you can get readiness information from the providers themselves. This is good for community-based providers. You can ask them specifically about their specific access to commodities and training and supervision that they've received. If you want to look at provider practice, then we recommend using the simulated client and the direct observation. The biggest difference between the two, of course, is that during the direct observation, the provider knows that they're being assessed. And so they may change and alter their behavior because of that, of course, the Hawthorne effect. If you're interested in provider knowledge, you can get this through the provider interviews. You can just give them simple quizzes about their various knowledge of quality practices, our family planning knowledge overall. And I included direct observation and provider knowledge assessments, but because the provider knows they're being assessed, you can make the assumption that they're acting on their best knowledge of how to do quality practice, since they know it's a test, essentially. For looking at client experience, the simulated client is good for that, and also client exit interviews. And within the client experience, we're also including the realm of respectful care. We think those are good tools to focus on if you're particularly interested in measuring that for family planning. I think on one of the surveys, someone mentioned they were interested in looking at phone-based methods that they could implement in the so-called COVID era. We have done the facility audit, the in-charge interviews were all conducted over the phone and it worked well in Malawi. We also did provider interviews on readiness and then provider interviews with clinical vignettes. We have done those over the phone and we can talk about our experiences more with that later in depth. Another issue with family planning is the volume of the facilities. If you want to look at practice and do a direct observation, you know, doing that in low volume facilities where they're seeing maybe a handful of family planning clients per week, it's not very feasible to do. Your team would be waiting out in the field for a long time, waiting for clients to show up. So we did highlight the methods we thought were appropriate for low volume facilities. And that is the readiness interviews, the knowledge quizzes, and also simulated clients are good for low volume facilities as well, we think. And then of course we wanted to highlight the expense because that's obviously a really big consideration as well. The least expensive in our experience are the in-charge interviews and the provider interviews, and that's mostly because they can be done over the phone, which saves a huge amount of money, of course. Simulated clients and client exit interviews, we gave two US dollar signs to, because they do involve field level data collection, which of course has its expenses. And then finally, the direct observation we considered the most expensive of them all because it does, with family planning, we have found it best to use clinicians to be the observers and recorders of those consultations, and they are a bit more expensive than your typical survey interviewer. So with that very quick overview, I'd like to pause here and hear from the participants. Specifically, we're interested in, have you used any of these tools previously? What challenges or benefits did you find with these methods? Were they adequate to measure implementation strength and quality of care in your program and setting? And if you haven't used them, are you considering use of these tools in the future? So I'd really like to stop here and hear back from some of the participants. So please go ahead and unmute if you'd like.
I can go. Oh, okay. All right. I do, for my current project, I do intend on using the facility audit, which is the in-charge interview. I've never used it before myself in SRHR projects before, so this is my first time. I am actually a little bit surprised that the direct observation is cheaper than the simulated client. But I get your reasoning makes sense that you need a clinician to be the person who does the direct observation. However, how hard is it to do the simulated client piece? Because I think a big chunk of it when I read the tool is the training of the clients. And was that done by your team or was it done by like the consultants that you hired to do the actual data collection? Like how does this work out?
Yeah, no, thanks. That's a really good question. With the simulated clients, and I'll go over our entire process later. First of all, we did work in consultation with our data collection team, but we co-facilitated the training, so we were involved with that. The Marie Stopes organization in Malawi, BLM, they use simulated clients for their routine monitoring for family planning services for the BLM clinics. So we hired their training consultant to come help us do the training for the simulated clients. Because we were a research study, we wanted to have very highly trained, highly standardized simulated clients with the exact same case scenario so we could compare across the districts just to answer our specific research questions. However, other organizations, and I know this has been done in Kenya and probably other places as well for family planning, they actually hire local women that are actually live in the catchment area of the clinic, and they go to the clinic and actually present their family planning history and their needs and their and and their methods they're interested in using, and then interview those women. So that would be something that would be a little more cheaper and a little bit more, closer to an actual patient. So thanks, that's a great question.
In the Kenya example, I guess they would be more using the client exit interviews rather than simulated client tools.
Yeah, that's another good question. I guess the difference there, and a lot of our questions in the simulated clients and the client exit interview tools are very similar. And one of the reasons we wanted to do that is because we wanted to compare the two. But you could certainly consider asking the same sort of questions in a client exit interview to those simulated clients. The only difference is that they were talking to the women ahead of time, training them, giving them a little bit of training on the process, telling them things to look out for, going through the tool together, so they kind of had it marked in their head what they should remember, and then they interviewed them afterwards. Yeah, so the same sort of questions you would get in a client exit interview, absolutely. All right, thank you. Any other questions? Did someone else unmute?
Yeah.
Okay.
Yeah, I'm familiar with the 4 except the simulated plan. I was wondering what's the difference between the direct observation and the simulated plans that give us the simulated plans give us client experience, but not provider knowledge.
Yeah, no, that's another great question. Thanks very much for pointing that out. So with the simulated client, the main difference is that the provider doesn't know they're being assessed. So the clients were trained, they were given a case scenario, and they were trained to present to the facility sort of mixed in with the normal family planning clients that were in that facility at that day. And consider that picture in your head with what happens during a direct observation, where you have a team that pulls up in a big, a big 4x4, and there's a lot of activity. They're talking to everyone at the clinic. There's a clinician who most likely is a supervisor of the person or ahead of them that's actually doing the observation, and standing there with the woman and the provider and marking things off on a checklist as the provider has this consultation with the women. So with a direct observation, it's essentially like a testing situation. It's an assessment. Everyone knows the provider's being assessed, the providers are being assessed. So you get different data. I'm glad that you asked. Simulated client can't really assess provider performance. We try to sort of get at that. Like with the simulated clients and with our client exit interviews, we ask them, did the provider tell you the side effects of this method? Did the provider ask you your reproductive history? Did the provider take your blood pressure or take your weight? So we're trying to use a simulated client to sort of get at some performance indicators, but it is different from having an experienced clinician sitting there ticking a checklist and doing their own assessment. So yeah, I agree with that.
And this is Melissa. I wonder if I could just add that, of course, when the clinician is being observed, he or she knows that he or she is being observed. So you have that Hawthorne effect. We've found that the quality still isn't always super high, and they don't do everything they're supposed to do when you're watching them. But this is one advantage of the simulated clients over the direct observation, as far as how much we rely on the data. So I think we know that there are limitations to both, but we think there are strengths to both that should be considered.
I have 2 questions, one on client exit interviews. Well, we use that to assess quality of care on our midterm. So my question is, there is a bias for sure when you ask the client immediately after the service. The question I have is, there are studies which show that client satisfaction will not really translate into quality of care. Because the way we assess quality of care from provider's perspective, objectively observing, or clients' perspective are different. So is there any way we can reduce the risk of inferring that from client's perspective only that quality is poor or good? So that's a big question. There are conflicting studies. The other one is on the in-charge interviews. We use this for our health facility assessment in several countries. So you do at baseline and see higher level of quality, and then you do midline or inline, and quality, you see quality reduced because of that person's interview. Is there any way that you can check who should be eligible to give an interview, how long that person should be in charge? Because the level of knowledge of the facility or service being provided is completely different. So we see conflicting results between baseline, inline, or midline. Thanks.
Yeah, no, that's very interesting and a good point. So I'll start, and then hopefully the rest of my team, or even John, if he's still following, can hop in with any questions or with any additions. So the first one was on client satisfaction, and that is something we really struggle to measure. As I'm sure you've noticed as well, clients tend to report the service was great, even though it may not have been great, and client satisfaction tends to reduce the longer the clients wait. And then also, I can't remember the other factor, but I think it's mostly associated with how long the client has to wait for services, which, I mean, it is annoying, and it is part of the overall positive client experience, but it isn't necessarily correlated to the provider behaviors. So we've tested some other different ways of measuring client satisfaction, and we haven't really come to any conclusions the best way to measure that. But again, with the client exit interview, that's why we wanted to include some direct questions about specific provider quality activities that the provider did. Like, did you get the method that you wanted when you came to the clinic today? You know, that has to go with client method choice and things like that. Did the provider tell you when you should come back? Did the provider tell you what to do if you missed a dose? So we're trying to really get beyond satisfaction and get some more quality, some more behavioral quality. Diwakar and Melissa, I know you worked with client satisfaction. Oh, and Emily too, in other program areas. Did you want to add anything about that?
Yeah, thanks, Elizabeth. This is Emily. We had a similar experience in Mali where everyone thought everything was great, even when by our standards, we thought it wasn't. And this brought up, you know, there's a lot of issues about measuring client satisfaction by sort of like intrinsic human rights perspective, but also being in a culturally relevant way. We did a qualitative study in Mozambique in order to try to figure out what are local perspectives of satisfaction. The program we evaluated, there was a nutrition-based household counseling session. So we did focus groups and talked with community members about what do you look for when someone is coming to your house to give you a health service, and what do you like about those and what don't you like about those. And from those focus groups, we were able to come up with some culturally appropriate quantitative questions about client satisfaction. It's a really tricky topic, which you were right to bring up. And I think there are some really interesting questions around, well, what does it mean if any service, regardless of quality, people are happy with? And what does that say about the types of services that people are receiving? But that is, so it's still something that needs a lot of work, but that is kind of how we try to get around it in some of our future work.
I think I was muted, sorry. So for some of the facility audits, the in-charge interviews, that's a very good point to make sure that you're trying to talk to the right person. I believe with our tools, we contacted the in-charge and asked them essentially if they were the right person to talk to. You know, are you near your drug stocks? Are you near the register? Can you answer these questions? And if not, they would we would ask them an alternative person that we could call. But that's a really good idea to quickly, maybe we'll look at, I believe we did collect information on how long the in-charge had been working at that facility. So maybe we would, that would be important information to capture if someone is new and doesn't know the ins and outs of the facility as well. So that's some great feedback. Thank you.
And sometimes the in-charge is probably not the most valuable informant as well. So it may occur that in a very large facility, there may be somebody else who's much more aware about the pharmaceutical stores or the drug supplies. So in those instances, we actually chose to ask the key informant and ask the in-charge who would probably be the best person to kind of give us this information. So when we mean by the in-charge, we shouldn't probably be too rigid about that this is the only person who can ever provide information on this issue.
Finally, I would just add that we would actually look at the commodities, not just take the word of the person responding about whether commodities and supplies were present. We would actually have somebody check to verify.
All right, any follow-up questions or questions on other topics? Or anyone else would like to talk about their experience using these tools?
No, I just dropped a question on the chat about simulated plants. It appears to me that it is based on a trained kind of but blind folded kind of participant joining the service. Would it, how is the methodology in terms of sample size and so on? Would you cover that later when you go in detail, considering the costs of recruiting, training, simulants?
Yeah, absolutely. In this upcoming presentation, I'll do a quick overview of how exactly we did, or what exactly we did for the Malawi implementation. In terms of sample size, I believe it would be similar to doing a direct observation. Well, no, maybe that's not the best one. Maybe it's more closely to a provider interview. So each simulated client interaction would be a measurement on one provider or one facility, depending on what you're looking at. So we do have some sample size tools, and that's something we could go over maybe later in the presentation if there is interest in it. So.
And sometimes the simulated client, you're also restricted by what kind of scenarios that you can train on as well. So you make a facility, you may be able to train 3 different simulated clients for the same facility. So you could send 3 different people who could pretend to be clients, and each provider then would be tested on 3 different scenarios without the provider actually knowing. But then again, the sample size would again depend on what is the indicator that you're looking at and whether the indicator is being answered by all 3 scenarios or only one of the scenarios.
That's a good point, yeah.
Well, this is Clarissa. I would just like to very briefly share an example from another project, Tamani project in Tanzania. It's a maternal care project, and we did an in-charge interview at the beginning to assess which health facilities were most in need and what kind of structural contributions we could do to the health facilities. We also did direct observation after BMARC and EMARC training in terms of OSCEs. So after 6 months, a year and a half of the training to capture retention. And also a client exit interview to assess satisfaction on respectful maternal care. So I thought that was interesting to highlight the different timing of the data collection. We will redo the facility audit at the end, kind of to have that before and after, but both the direct observation throughout the project and the client exit interviews kind of midway to assess the quality of care midway on the project. So I just wanted to share this example.
No, thank you very much. And that's I think that would be, yeah, and I'm so glad that you talked about the timing of your of the various tool implementations, because I think that that is something that people can choose. Like, you don't have to do this all at baseline and then at inline. I think it would be common, most people would be interested in doing the more implementation strength assessment interviews and tools, because they can be done by phone, do those more frequently or at baseline and inline, and then sort of like a midway assessment of the quality of practices. Yeah. So thanks for bringing that up.
So in terms of direct observation in communities which are conservative, don't you think that, like, what has your experience been in terms of, getting a more accurate overview?
Yeah, that's a really, really good point. One thing that we've done in this implementation, also in other implementations as well. Well, I think we only were able to do this successfully in the interpartum implementation, is to hire female assessors, which helped a lot. For Malawi, we use both male and female assessors for the direct observation. As part of their training, we try to be sensitive to the confidentiality and privacy of the woman by training them to do things like stand near the woman's head during any vaginal exams, and only observe the vaginal exam if they were actually doing something like inserting an IUD or something like that. But yes, no, having the assessor there will alter the client's response, possibly, and may even alter the provider's practices in more conservative societies. I wonder if you have any experiences from your own work to share on that at all.
Yeah. Sorry.
Go ahead.
Okay, yeah. So in my experience, what I've found is that client exit interviews kind of work the best. Direct observation, again, both the provider as well as the client, they're not very. You're not sure of what's going to, what your assessment is like. With simulated clients, again, you see, at that point in time, it's okay, you get your result, but it leaves a very kind of distrust with the service providers over there, because once they find out that that's what you've been doing, although you kind of initially also get the approval and all that, but it kind of creates that mistrust, which I feel. But in my experience, I think I found to have a general assessment of the facility, the in-charge interviews and the provider interviews, to get an overall feel of how the system works, that works better. But in terms of getting how the service has been, how satisfactory or unsatisfactory the service has been, client exit interviews have worked the best for me.
Oh, thank you. That's really helpful.
Thank you.
And you also mentioned the OSCEs as well too. How did that work for your team? Oh, was that someone else?
Yeah, that was someone else, I think.
Oh, I'm sorry.
No problem.
Apologies. Yeah. Emily, go ahead. Yeah.
Sorry, I just wanted to say, I think that you mentioned like working in sensitive communities. And so we did this for our interpartum study because we had, those of you who attended the webinar last week, we had observers do direct observations of women in labor and delivery. And knowing that that was quite invasive, and knowing that asking a woman in labor to consent to something she's never heard of before is, quite a big thing to ask. We actually had community health workers, I believe, in the communities in which we were doing these observations, inform people, hey, this might happen if you give birth at a health facility. There might be someone who asks you to participate in this study. It's an observation and you can say no, but just be prepared. And I think that was a way to kind of bridge that gap.
Can I just say something to that? Yeah. So what my experience has been that, women usually, it depends on the need, right? If they really need to go to the health facility and if it's free services, they don't have a choice. So they'll absolutely agree to whatever you say. And that's why, in conservative societies, women usually go to midwives, right? Or the traditional birth attendant. So I think it depends on how desperate they are. And because, especially if there are other men or, usually there would be no men, but suppose, so it just depends on what the need of that woman is, how vulnerable she is and all that. So I think that those are some other confounding factors which are there.
Yeah, that's a great point. Thank you so much for bringing that up. Yeah, that definitely that some of these tools respect the autonomy of the clients a little better. And we may ask them if it's okay if we do direct observation, but as you rightly point out, they don't have a choice in the matter. So of course they say, yeah. Thank you. That's a very important point.
Sorry, Elizabeth, this is Cynthia. I've seen John raising his hands for a while. Are you still there, John?
I'm so sorry. Yeah, I haven't figured out how to monitor the chats and also the hand raising while I'm in presentation mode. So apologies for that.
I'm trying to unmute. Oh, John, I think he might be unmuted now.
Okay.
Yes.
Oh, yes, we hear you, John.
Yes, can you hear me now?
I hear you.
All right, thank you. I wanted to contribute. Yes, I wanted to make a contribution, especially on the direct observation. Yes, that it works very well, and people should not be worried as to maybe when they know that they are being assessed, the quality still aspect will still come out, because I observed in Malawi, especially in Mangochi, we found that even if they knew that they are being assessed, but we could still pick a lot of gaps from the providers. So to me, I feel like that direct observation assessment too was a very good one, and it could give us a clear picture of the knowledge gaps in the provider, and that one could easily relate with the exit interviews. What the clients could say could easily say something on the provider's knowledge and the skills. So I can see that even if they knew that they are being assessed, but yet we could see that there were a lot of gaps in terms of the quality being provided. That's what I wanted to comment.
Yeah, no,
Yes.
thank you very much. Yeah, no, that was a really good observation to include. I definitely agree with that, and also, particularly in facilities that are pretty remote and hard to reach, they often don't get, direct supervision as often as they would like. So having the direct observation protocol is also, it's a measurement tool, but it also puts the providers in contact with a supervisor who could also work to help improve their performance after the assessment is done.
Yes, exactly. Thank you.
On that note, actually, because most of the countries, at least where my project works in, they do have an external supervisor who comes and visits every so often, right? Did your team use like somebody who is already part of the system, who, for example, does these supervisory visits, or did you actually hire clinicians separately to do the direct observation?
John, if you caught that question, would you like to respond to it?
Yes, I got that question. In this case, they were our family planning experts. We call them master trainers, the ones who are very conversant with the necessary steps to be taken in a procedure. So in each and every team of enumerators, there was one family planning expert who could really assess the quality. That is what I can say. So every team had somebody who was an expert in family planning. So that one is the one who was assessing the provision of the service in terms of the direct observation. That is
Okay.
what I can say for that. Yes.
Okay. Actually, that is very helpful because I think it's like I can see Nyla's point is if I go ahead and hire random researchers, it might be more difficult. But if you actually get somebody who's already part of the system, and is also part of like these supervisory visits, then I think it like maybe offsets it. I don't like it's not perfect, but yeah.
All right, thank you very much. Yeah. Anything else to add on this point, or does anyone have any other questions?
Excuse me, I have a question here. Did you notice any difference between the results or the findings from the simulated client and direct observation?
That's actually analysis we haven't done yet, but we think would be pretty important to do. Right away we did notice some pretty big differences between the simulated client and the direct observation. For one, in some of the facilities in Malawi, and John, please jump in with any additions to this. Like for instance, we found that some of the simulated clients were being turned away from accessing family planning because they refused to have an HIV test, and that ended up being sort of like a misrepresentation or misunderstanding of a district level policy. But that right there is something that we picked up in the simulated client that we did not pick up in the direct observation. John, did you have anything else to add?
No, that's exactly what happened. Yes, I totally agree. Yes, that's what the observation was like. So others could be sent out. Others, they could not have maybe the kind of family planning methods they wanted. Yes, for various reasons. Yeah.
Okay, thank you. Yeah. But we will be doing a more formal comparatory analysis of the data points as well.
Just one question. For the direct observation for adolescents, do you have any changes there? Do you have, like, are your tools specific according to age as well? Because I wonder if they would be able to express themselves if there's somebody in the room.
Yes, and that was definitely a concern of ours. We had the same tool for both the adults and the adolescents. So we collected the same information. We did collect the client age and the client exit interview, so we were able to distinguish between the clients, the adult and the adolescent clients. Off the top of my head, I think we had about 300 client observations. Yep, and maybe only a handful, 4 or 5, were actually adolescents. But our simulated client, one of the simulated client case scenarios was actually an adolescent, a 17-year-old unmarried girl, trying to access family planning services for the first time. So we were hoping to get more of our adolescent data from that protocol.
Yes, maybe I can add on that. Yes. So all right.
John, I think
Hello?
you can go ahead and then we can take a follow-up or another question. So please go ahead, John.
All right. I was saying that for the adolescents, yes, from our observation, most of them, they were not ashamed. They were very free because there was an explanation to them that in this room, we have these ones. We also have the provider. So they were told who we are, and most of the times they were free to express what they wanted. That's our observation. Thank you.
I just to add on that, so the tool, as you say, the tool has standard questions. Is there any way any organization can modify the tool to include adolescent responsiveness component into it? The other one is on direct observation. In our trainings, what we're doing is we use government Minister of Health approved trainers, and after training we do quality of care follow-up after 6 months, and also integrated supportive supervision, where those people will be doing direct observation, and if they see any gap, do immediately on-site technical assistance. So rather than using external person, even if we want to do evaluation, it's good to use Minister of Health people who are the trainers who know everything, and it will not be difficult for them to do observation because they know the checklist and everything. So rather than non-professional people, it's better to use those trainers.
Exactly, yeah, and we found that as well too, because our assessors for the direct observation, like John said, they were all the master trainers for family planning, and so they were very knowledgeable, but they were also able to give on the ground feedback to the providers once the assessment was over. So hopefully improving their performance as well. In terms of tool modification, we are greatly hoping that you can modify these tools and add and remove questions as you see fit. For instance, our in-charge interviews and the provider interviews were created specifically to measure youth-friendly health services portion of Malawi, so you'll see they're more adolescent youth-focused. So you could definitely, add on to those and modify those as well.
I was just wondering, while you were doing, implementing these tools and all that initially as a pilot, how much feedback did you get from, the facilities themselves? Like, was that incorporated into this?
Yes, we tried to as much as we could. So our process was that we first did a desk review of all the quality of care tools and indicators in family planning. So we looked at the QIQ, we looked at situational analysis, the SPA, the SARA. And then from that, we developed tools that were specific for the context for the Malawi Youth Family Planning Program, and also the later assessment for quality of care. And from those tools, we then took them to our non-study sites, and then we piloted them, particularly for the quality of care. We looked at whether or not they were clinically appropriate, whether they were capturing all aspects of care. We got feedback from these sort of like non-study providers. We also convened, I'm trying to think what else we did. Oh, for the in-charge interviews and provider interviews for the phone-based assessments, we did validation studies to see if the answers we were getting over the phone were the same as those we were getting in person. And then we also involved the program, the program implementers. In this case, it was the Reproductive Health Directorate of the Ministry of Health in Malawi. They were involved in the tool development and in the training and the data collection as well. The Ministry of Health folks were our direct observation assessors. So maybe I'll take a minute and tag Melissa and Diwakar. Was there any other steps that I'm missing in terms of our tool development and also getting feedback from the program implementers on the process and the tools?
No, I think you've touched upon each other. Like that's we kind of covered everything. So basically, we try to be as inclusive as possible. So, like for example, people like John kind of contributed to the tool immensely, and John is actually a family planning coordinator who's in the field in Zomba district in Malawi. And there were others who actually looked through the tools and kind of gave us specific information on what worked and what didn't work as well.
No, thank you so much. I'm sure you guys, the only reason why I asked this was because, like in the previous session that we had, I think you mentioned that there was a lot of training of the, the implementers who would be doing that, because I think that is such a great idea that if you involve the people who are on ground, if you first of all strengthen their capacity and then see how they implement the tools that you have, that gives them the trust and the confidence, and then they kind of execute that, there is that ownership in those adapting those tools and giving you feedback. So I just thought, like it was mentioned in the last meeting, I wondered if the same was applied to the family planning tools as well. So yeah, that was okay. Thank you.
Okay, any other questions?
More of a comment than a question, maybe. But as an M&E person, I personally find, and for me, at least in my SRHR project, and actually we have a few SRHR projects, our work in the health system change or with the health facilities is one piece of our work, right? I will be honest, I find the fact that there are 5 tools that I could be using to monitor and evaluate one pillar of our work is overwhelming from a personal standpoint. And what I find, and in my past experience, and I think I've talked to you, Elizabeth, about this before, is as an M&E person, we create amazing surveys, we collect amazing data, but then what I find is a good chunk of the survey data never gets analyzed because we run out of time, we run out of figuring out how we can use that data point. And to that point, the direct observation piece, so there's clinical elements to it. So there's the observation for IUD insertion, I think there's one for implant. And I like the nuance level of information that that's in the tool. It's about like if the healthcare provider did certain things before the procedure, during the procedure, after the procedure. All great points. However, as an M&E person, I find it hard to figure out how to use this nuanced data. But that's just like from my personal.
No, thank you. That's really great feedback as well. I do want to say that with these tools, we were trying to be very thorough and very complete. Trying to see what quality of information we could capture of things that happened during the consultation, after, before the consultation. So it was very, very, very extensive. And also a lot of our tools have repeated sections because we do eventually aim to compare the data from those two tools and see how they differ, see how they're the same. So that's why I also want to say I really encourage folks to take these and critically think about what their research question is, what their evaluation question is, what they really want to monitor. Look at the data, look at the indicators, and then just focus just on that. Particularly if you're looking at more rapid, more frequent assessments, it'll be really imperative to do that because agreed, I think there's a lot of questions that we include just because that's what you include in a facility audit, but we never look at it. So we definitely want to encourage people to think critically about this and really focus on the program.
Sorry, this is Melissa. I would just say if it's a point in on which the program can make a change directly in their training or their supervision, or there's a policy that could change in the the overall government or the district or the national government, then it's worth knowing whether people are doing it well or not. If it's too nuanced to be targeted with a change, if you find that lots of people are not doing it well, or it doesn't matter whether you do it well or not, then it's a good thing to drop. So I think we spent a lot of time in IOC really understanding the program well and really understanding the health system and environment, the sort of context around the program. And those of you who might be with the NGOs or part of the implementation, the program implementation team, will know that stuff, and you'll be you'll know the country well, and that's why we work so closely with both the implementers and other folks in country to ensure that all of that is clear. But yeah, as Elizabeth said, our intention is that you take these tools and you see what part is going to answer your questions and you focus on those parts.
All right, great. So thanks so much. So unless there's any other burning questions or points that people want to discuss, I think we can move into the tools. We still have about 30 or 40 minutes, so I think we're still on good time. All right. So I'll start by doing a really quick overview of the tools and then talk about the Malawi implementation a bit. So for the Malawi family planning evaluation, we did 2 different assessments conducted at different times and responding to specific questions from the Ministry of Health. The first one was an implementation strength assessment. The focus of those tools and that assessment was youth-friendly health services. It measured structure, equipment, commodities, supervision, training, and it was mobile phone interviews with all the health workers that provide family planning. So it was a census of the whole country, and it was conducted in 2017. For the quality of care assessment, we were looking at something slightly different. We were still looking at youth-friendly health services, but we were also collecting more data on adult services as well. The main question there was we wanted to look at the association between quality and fertility outcomes at the district level, and also assess family planning provider knowledge, practice, and client experience. The focus was on the National Family Planning Program and also a tool validity study. So that's why we're doing so many different tools. That's why we looked at so many different tools. We don't expect others to implement all of them. We looked at all the facilities and providers in 6 districts, and it was conducted in 2018. And just to correct something on the implementation strength assessment, we did develop the tools to measure the family planning program as a whole, but it's more focused on the youth-friendly part of it. So apologies if I misspoke there. All right. And we've got, we're going to go over this very briefly, but we've got additional details on both studies that are available in a report linked to the Radar website. You'll find more in-depth information on the methods and also the findings and the interpretation and policy implications of the findings as well. So starting with the methods of the implementation strength assessment, this is the mobile phone based assessment. There was the data manager first assigned a number of facilities to the teams. In the teams, there were some interviewers and a supervisor. The teams contact as many of those in charges are another appropriate person at the facility that they could reach by mobile phone. And for those that they couldn't reach, they then worked with their supervisors to make follow-up plans to attempt to capture all the facilities. As part of the in-charge interviews, one goal of that was to create a listing of all the facility community-based family planning providers, including their names and phone numbers. And from that, we built our provider listing. So from that, the data manager then assigned provider interviews to each of the teams. The teams did as many as they could, and then made follow-up plans with their supervisors for those that they couldn't reach. So just to talk a little bit about the follow-up plans, they were something as simple as varying the date and time of the calls to try to catch the person at a good time. They also included sending an SMS ahead of time to schedule a call appointment or reaching them through their network of coworkers. And in Malawi, at least, which does have very good network coverage, they were very successful. They were able to reach 660 of the health facilities in Malawi. So I think there were only 6 they couldn't reach, and they got over 92. They got 92% of the health facility-based workers, 98% of the HSAs, which is a community-based health worker cadre in Malawi, and 93% of the CBDAs, another community-based health worker in Malawi, which is pretty impressive since a lot of them actually work in very remote rural locations. So with the implementation strength assessment, Form 1 is the in-charge mobile phone interview. It provides the family planning provider listing, the names and phone numbers. Also some program information and demand generation activities that are carried out at the facility level. The provision and availability of contraceptive supplies and equipment, facility level supervision, and also utilization. Form 2, there were 2 separate forms used for facility and community health workers. They collect information on health worker demographics, training and supervision, demand generation, behavioral change activities that the provider themselves had carried out, and also the availability of contraceptives and supplies to that specific provider. And in both Form 1 and Form 2, we had sections on call attempt tracking. All right, I see there's questions popping up in the chat, so please do interrupt me if there's anything I need to address right away. Okay. So moving on to the quality of care assessment, this was carried out in 2018. The way that we did this is we, again, called all the in-charges in the facility, and we updated our provider listing because there was about 6 to 7 months between the two assessments, and we wanted to make sure we were working with the most up-to-date list. We, from there, and of course, we only did this in 6 districts. This wasn't done in the whole country. So once we had that listing of providers, we called them all, or attempted to call them all for recruitment and consent purposes. So by the time the simulated clients came to the health facility, the health workers, all of the facility-based health workers had been told that a simulated client would be visiting them. So the first was the simulated client visits, and then the team went back to the facility and followed up with direct observation, exit interviews, and provider interviews. So for the simulated clients, we did that, those were done only at the health facility. And the provider knowledge quizzes and clinical vignettes were done with health facility workers and also the community-based workers in Malawi. And we did direct observation and client exit interviews in the high volume health facilities of Malawi, which we defined as more than 30, average of more than 30 clients per day. Or no, more than 30 clients seen for the previous month. So, all right. So I'll talk a little bit about how we did the simulated client. So we did work with study staff, and we trained them to adopt standardized case scenarios. They adopted one of 2 standardized case scenarios. One was an adult wanting to switch family planning methods, and one was an adolescent, unmarried, wanting to initiate contraceptive use. Their assigned preference was pills or condoms, and they were only trained to only accept those because, for their own protection, we trained them to avoid all medical procedures, including pregnancy tests, any injections, pelvic exams, blood draws. Measuring weight and blood pressure were okay, and of course, they could only accept pills or condoms. We trained them to deploy exit strategies if offered injectables or implants. And at least in Malawi, where injectable use is so high, that they were often, sort of encouraged or pushed to use injectables. They adapted their costumes and backstories to the local context. I'm showing some selfies of one of our simulated client staff. On the right, she's dressed for a Muslim majority district, and on the right, her costume is more reflective of a non-Muslim majority district. So the simulated clients were dropped off nearby to the facility where they could walk unobserved from the car to the facility itself. And there they presented with the other family planning clients. After the consultation, they walked back to the vehicle and were interviewed immediately using the checklist by their supervisor. That checklist, our Form 3, documented experiences during pre and post consultation, including the completeness of the client history taken in counseling, information on contraceptives received and prescribed, and also respectful care and negative experiences. Form 4 was our provider knowledge quiz, and we administered this to facility-based health workers and the community-based health workers. It included questions on provider demographics, knowledge of complete counseling, side effects, contraindications, and also we did include some methods about what supplies or contraceptives are available to you today. For Form 5 is our clinical vignette tool. We have 3 clinical vignettes, including 1 practice. So we presented them with a short description of a client and then asked them which client history questions would you ask this particular client, what exams would you administer, and then finally, what methods would you recommend? The direct observation checklist looked at completeness of client history taken in counseling, information on contraceptives received and prescribed, respectful care and negative experiences, and we were also able to document clinical activities, including injectable administration, insertion and removal of implants and IUDs. And then finally, Form 7 is our client exit interview. It collected information on the client family planning history, the completeness of client history taking and counseling during the consultation they had just left, information on contraceptives received and prescribed. We asked them about some respectful care questions and any negative experiences. And then also we included some household decision making around family planning use. All right, so that is our the quick overview of our tools that involved in this. And I think we've got about 20 minutes or so to review the tool package on the website. So I'll go do that now. Maybe I can just take a few seconds as I switch to see if there's any questions or any comments at this point too.
Just a quick question on simulated client. It seems like it's a mystery client in corporate world. So did you tell them the day they are coming or the time they are coming? If not, I'm wondering what's the purpose of telling them that mystery client is coming? Because if you tell them that day, they will be prepared. And even we know from Western world, when you hear anywhere in media that something is happening, so they alert their customer service people that they should take care of. So there will be a big bias. So what's the purpose of telling them that they will be receiving mystery client?
Yeah, no, that's a really great point and something that we grappled with as well. So because we were doing this for research purposes, we were obligated to provide informed consent, which includes that they would be visited by a simulated client. So our consent form was that we told them they might be visited by a simulated client at some point in the next 3 months. So so they didn't know who the person was, when they'd be coming. They didn't even know there would be 2. So we tried to address that as well as possible. We also and then of course, because of some various reasons, we did have to once the consultation was over, because the team was coming to do the direct observation, the interviews, we did have to inform them that they had been visited by a simulated client earlier that day. But just anecdotally, often, I mean, they're getting 20, 30 clients per day. I mean, they have no idea who it was. So we are hopeful. We didn't collect any hard data on whether or not they really knew if the simulated client remained masked, but anecdotally, we're pretty confident that she was still masked.
Well, how did you come to this 3 months period? It's random number, or that people, because the service providers will be tired of waiting for clients. So 3 months is a long time for sure.
Exactly. Yeah. We picked something that seemed like a long time, but still within the study window. Yeah. So you could definitely pick another number. Melissa, were you unmuted for a second? Do you have something to add?
No, I'm okay. Thanks.
Okay. Yeah. All right. Yeah. So just want to do a quick check. Can you see the family planning website on my screen?
Yes, we can. And I'm just noting for everybody here that we did reshare the URL and password in the chat if you'd like to access that directly.
Okay. Thank you so much. Yeah, so so I am on the family planning tab of the website. And if you scroll down here, there's just a quick introduction of the 4 methods that we used, a paragraph about the evaluation itself. I did give a little overview of the Malawi implementation and the family planning breakout room of the July 20th introduction webinar if you did attend. Excuse me, if you didn't, I believe that recording is available, but you can also access the slides from that breakout room as well. The tool review, I'm going to go now. These are links to everything in Google Docs. Within Google Docs, you can comment or respond to other people's comments. So feel free to do that either as we're going along or after this webinar is over. I also wanted to point out some of the additional resources that we have. We've developed these family planning guidelines that we're hoping will walk folks through how to implement an assessment specifically for family planning, from the planning stages to the budgeting stages, training, implementation, all the way through analysis and interpretation. So please do remember these resources are available, and let us know if there's anything else we can add to this. We also have a pretty extensive list of worksheets and annexes that go along with these guidelines. So there are things like a sample size calculator, a supply calculator, budget templates, some logistics documents, some performance assurance documents, and then also something around some documents and guidance around indicator calculation, review, and interpretation. And then finally, at the end of this, we've got links to the IRB applications for the implementation strength research protocol, the quality of care research protocol, and then also the final reports. We'll find more in-depth information about the methods and the findings. All right, so going back up here, I'm going to start with the in-charge survey. All right, so all of these tools are in Microsoft Word, but they were created to be adapted easily to ODK. So one thing that you'll notice is we're going along, instead of using skip patterns, we're usually using enabling conditions, which is just a little bit easier to transfer into ODK. So this is the in-charge survey implemented, administered over the phone. So we've got a little bit about an introduction. We do want to make sure that the in-charge is in a place where he or she can access the register, access the stocks and other information needed. We do give them an opportunity to assign an alternative person if they say that, you know, I'm not on site long, I'm not going to be on site long term. Oh, did someone have anything to say? Any questions? Okay, maybe it was just my connection went out for a second. We do give them an opportunity to designate someone else to go through the questionnaire with us. We do ask them a language preference, and we did have interviewers on staff that were able to give the interview in multiple languages if necessary. And so then we start with our listing. We ask them, does your health facility provide any family planning services? Do you have any community-based health workers that report to this facility? And then from that, we build our listing. This is just the consent. Okay, so this is just a little bit of some of the repeats. Okay, sorry, I skipped ahead a little bit. First start with in-charge, some questions about the in-charge, about their background and their information. We do ask them when they started working as an in-charge at this facility, so that would be interesting to go back and see how long some of these in-charges have been working. Now we get to the family planning provider listing. So how many of the different cadre work answer to the facility or work at the facility as the catchment area. We get their names, their positions, and their phone numbers. This is a looping set of questions, so the ODK automatically loops this for each of the providers. We then ask a series of questions about accessibility of the family planning services. How many days a week do you offer family planning? How many hours on average is the family planning service delivery session? Which days do you usually have? So again, some of these are pretty in depth, but you can pick and choose which one you think is most relevant to your context. Then we ask a little bit about mobile outreach clinics. This may not be applicable to you. We talk a little bit about what types of family planning methods does the mobile outreach clinic provide. We did tailor this list specifically to what was typically provided in Malawi during mobile outreach clinics, so you can revise this as necessary. Because then we have a series of questions on demand generation and behavioral change, with a little bit of a focus on also youth events and youth meetings, community meetings. Some more information about peer educators. So that, and then we do availability provision of contraceptive methods, supplies, and equipments. Again, feel free to sort of peruse these a little more carefully when you have time and leave us comments and questions. We will go back and review them. We're looking at the guidelines and the protocols. I definitely agree that it would be good to make sure that we're capturing the most recent guidelines and protocols, as those do change. We've got general family planning guidelines and protocols, ones that are specific to youth-friendly family services. We've got information about pet pamphlets and other brochures that could be given to families as sort of an outreach. We do ask about job aids. And then we do ask a little bit about privacy. Does your health facility have a room where there can be auditory and visual privacy? During this interview, we also embed some questions about utilization. It's not technically really implementation strength or quality of care, but it is a good place to capture utilization, which can be important to look at. We do want to make sure that they have access to their registry before we ask them, so that they're not just, you know, coming up with rough numbers, that they're sitting there and they're counting the number of in the registry, or looking at the sum of the utilization for the most recently completed month. And then we go into, does your facility provide each contraceptive supplies, male condoms? Are they available today? Has there been a stock outs in the most recent 3 months? Agreed that I've also seen some implementation strength or readiness assessments that go back to 6 months. But I can't remember why we picked 3. I don't know, Diwakar and Melissa, if you want to jump in or not, but just think about what's relevant to your evaluation question in your program.
So the reason for the 6 month versus a 3 month was 3 month was more immediate. Rather, the 6 months, considering the fluid situation in many of these countries, they could have faced really tough challenges in the face of a year. So we want to know what was the most recent experience. That's the reason why we stuck to the 3 months rather than a 6 months.
Yeah. Okay. Thank you.
One more quick thing that I wanted to quickly talk about here is sometimes many of these facilities don't have an in charge, or that in charge has gone somewhere else. He's not available. He's on leave, and if you keep asking, they'll say, I'm not the in charge. But then we'll have to quickly focus on whoever can provide us the best possible information and not get focused on the fact whether you're officially the in charge of the facility or not.
Yeah, that's a very good point.
We face a situation quite a lot in our thing where many times the in charge would be on leave, or they would have been deputed somewhere else, and somebody would be just acting in that place for the moment. And we went ahead and kind of make sure that they understood that all we are asking about is about the facility, and just to make sure that they understand that this is not an evaluation of them, but rather that of the situation of the facility.
Yeah, thanks very much. Yeah. All right. So we, and again, you could tweak these to add questions about male and female sterilization or emergency contraceptives. Again, these are just contraceptive supplies that were most relevant to the program in the context. So then we collect some information from the family planning register, number of new clients, number of clients that received specific commodities during their visit, going through all the contraceptives. If there's any specific days that they provide, or any NGOs that provide specific contraceptives. And then we do facility level supervision. So during the provider interview, we ask them specifically about supervisions or trainings that they have received, but we also collect this at the facility level as well. All right, and then in survey, any questions about that? Or I think I'm going to skip over the provider interview questions and instead pick one of the quality of care questions. So before moving into quality of care, was there any other questions about the facility audit or provider interviews?
Can I, sorry, Elizabeth, before we go on, how successful have people been with getting this utilization data from DHIS? Others on the call instead, because you certainly, if you feel confident that you can get the data and that it will be somewhat usable, you could eschew all of this utilization data here and get it out of DHIS. Does anybody have experience with that?
Sorry, Melissa, was the question about how whether it's possible to get the similar data from the HIS?
Yeah, I was just wanting to hear people, because I imagine that people listening to this would say, well, that's a lot of time getting stuff out of the facility registers when you could just be getting out of DHIS. Just thought we could spend a minute or two hearing people's experience with that.
I'm not sure if the DHIS will have these kinds of questions. They have questions about the service provision.
I just meant the utilization, the number of clients on their lists.
That is possible. I mean, if the partner working has access to DHIS or through a third party, or they can request it from the ministry. In our project, we have access to that and we can pull data easily.
It's just that in other places, we have found it very difficult to get this data through the DHIS because nobody's given access, and the ministry guards this data with great secrecy as well. So sometimes we are forced to ask this using these kind of questions through provider surveys. Basically, just the data that they've already reported elsewhere and which is easily available through a database.
Well, to be clear, for the case of, I mentioned for the Canadian Red Cross, we as Canadian Red Cross don't have access to this directly, but through our local partner, the Malian Red Cross, and then they share it with us, but there's an agreement with the Ministry of Health, and the Malian Red Cross holds the password and the access information.
It's a nice arrangement, and I think it would be great if that worked in many countries. And maybe we should put something in our manual that says that that you could collect it either way if you're confident with the quality and accessibility of those data. So I didn't mean to derail us. I just wanted to call that out before we left it.
Yeah, no, that's a very good point. Yeah, thank you. So now we've got about 10 more minutes, and I was going to pick one of the quality of care tools to do a walkthrough similar to what I just did for the facility audit. Is there any particular tool that I should focus on? Should I do direct exit interviews, or should I do the simulated client? Do folks have a preference?
Should we raise hands?
Yeah. Well, someone will have
Everybody
to do the
okay
count
with
for me.
Everybody okay with doing simulated client?
All right. Well,
Sorry,
go ahead. Okay. Yeah. And then maybe if we do have a little bit more time, we could do the client exit interview, since that seems to be the other tool that people are interested in as well. So, all right. So this is just, we start with some administrative activities. So then we do, and again, the simulated client staff had been briefed on all of this ahead of time, so they know that they're going to need to be tracking how long they're waiting to be seen. So the supervisor then collects that information, how many minutes and hours. They ask some information about privacy. Did anyone overhear your registration process? Was the waiting area private? And then they go into some information about what happened during the actual consultation. In Malawi, and I think in a lot of other settings as well, they do group counseling. So we had some information. We asked some questions about whether or not the simulated client did individual counseling, group counseling, or a little bit of both. If it was individual counseling, we then asked her, was it done in an area where it was private, where no one could see you, where no one could hear you? Do you feel like you have enough privacy during the consultation? We added this question about, did the provider greet you or the group respectfully? Did they ask you or welcome any opportunities for you to ask questions? So again, this is being administered very soon, excuse me, very soon after the consultation was complete. So hopefully all the details, these sorts of details, were fresh in the client's mind, the simulated client's mind. So these are getting a little bit towards respectful care and client-centered consultation. Did the provider answer all your questions? Did they interrupt you while you were speaking? Did they stop the consultation to conduct any other business, whether it was business related to the clinic or they were, checking messages on their phone? Did the provider verbally assure you of confidentiality? Did they look at your health card or documented passport at any time? We did supply the simulated clients with a doctored up health passport to sort of help their to help keep them masked. And also, did the provider use any visual aids? So finally, and then we move on to asking the simulated client if the provider asked her any questions around taking her history, her medical and reproductive history. Did the provider ask you your age, the number of children you had, STI status, chronic illnesses? And I must say, this does look a lot nicer when it's on the ODK. So it is a little easier, nicer formatted, and a little easier to navigate through. Whether or not you have a husband or a boyfriend, what is your partner's attitude towards family planning, desired status for more children, or desired timing of more children, smoking status, things like that. And then we asked them specific activities the provider did during the consultation, asked them about any exams, specific exams such as blood pressure, weight, checking for anemia, anything else. Then we move on to, did the provider explain any of the exams or procedures before they were performed, telling you what they were doing and why? Then we go on to a little bit about counseling, general counseling, starting with, did they talk to you about any contraceptive methods? What contraceptive methods did the provider talk to you about? And again, this could be during individual or group counseling as well. Did they mention anything about pills or condoms or implants? Did they ask you your preference in contraceptive methods? Do you have a sense that they were advocating or pushing you towards one specific method? Then we get into, were you prescribed, given, or referred for a method during this visit? We ask them why. There's an opportunity for them to take that, well, there was nothing in stock. Then we ask them about which specific methods. Was it available to you the day of the consultations? We do ask them, we try to get at why it may not have been available and what was not available at the time. Why didn't you receive the perceived method? So again, this is a little bit repetitive, but we're trying to capture the full picture of the information and the consultation as it happened. Then we get into some specific counseling, like, did the provider explain how to use this method that you received? Did they talk about the side effects? Things like that. And then it goes into more specific details, like if the woman was given the pill, was the simulated client, did the provider talk to her about the mode of action? Did she mention it was reversible and short acting? Did she tell her that you have to take it daily? And to talk to her about side effects, tell her that she needs to return to the side effects, return to the clinic if the side effects persist. So basically trying to capture the complete counseling as much as we could. And then also for injections, condoms, and IUDs. So this is just the general counseling implants. Then we tried to get at some more of the respectful care details. Was there any sort of, I don't know, threats about breaking confidentiality? Was there any discussion of informal payments? Was there any sort of negative behaviors raised? Did someone yell at you, use a disparaging term, anything you consider disrespectful or abusive? And then we also tried to capture specifically what was done. We did have the simulated clients fill out field notes at the end of each day. They did one clinic per day. Yeah, I think it was one clinic per day. So we did give them an opportunity to write a more detailed description of what happened, and that was really helpful for us in interpreting the quantitative data, and also capturing some events that occurred that the quantitative tool didn't capture. Then we have just a few follow-up questions about what happened after the consultation was complete. Did anyone else ask you for any additional money? Did anyone else treat you in a disrespectful or negative manner? And then that's it. So any questions about that? I'm looking at the timekeeper. Should I go to the client exit interview or should we go to the closing and next steps?
You've got about 12 minutes.
Okay, so I think I'll just go over the client exit interview portions that are distinct from the simulated clients. Excuse me. All right, so for the client exit interview, the client had this was the same client that was assessed during the direct observation. So we came up with this client ID code and client color just to track the clients as they were coming and going and making sure that the interviewers were approaching the correct clients. We collect a little bit of information about the client, her age, her marital status. In Malawi, the family planning clients vast majority are female. So these tools were developed to that context, but I think a lot of these questions could be adapted for male family planning clients as well. The client's religion, her education status, we collect some information about her previous use of contraceptives. I think these questions are pretty standard and come from the SPA. What method were you most recently using? What was your main reason for visiting the family planning clinic today? Did the provider ask you any questions about did you have a problem with this method? Were you actually having problems with this method? Did the provider suggest any actions for you to do? What was the outcome of this visit? And yeah, definitely noted that one outcome is that the client could have just been coming in for information. So that's something that we could definitely add to the response bank here. What was the client's intentions and switching methods? What did she want to use? Which methods did she want to use? Did the provider talk to her about any of the methods that she just mentioned? Did they talk to you about any contraceptive methods at all? And again, this is contextualized to capture information that was given during either individual or group level counseling. Did the provider talk to you about any other family planning methods than the one that you were interested in? Did they give you the list, the constellation of services provided? Did they ask you about your preference? What were you given during this consultation? Yeah, what exactly were you given? Was it available to you today? So these are all the same sort of questions that we asked in the simulated client. Which of the method was not available and why was it not available? Yes, definitely a good point that one of the reasons they didn't access the method is because they had to get special permissions from either a spouse or a parent or guardian. We do collect some information about the outcome of the visits and particularly around her on whether or not she wanted to start the method, if it was a new method. Was she given the recommended method and why not? Did the provider explain how to use the method, side effects, what to do if you have problems, when to return for follow-up? And then we also asked a question of, does this method protect against sexually transmitted infection like HIV and AIDS? Then we went into some knowledge questions just to assess the woman's knowledge about the family planning method that she received. So for instance, if she was given or prescribed a pill, we ask her, oh, okay, how often are you supposed to take this pill? You know, how often can you use a male condom? Types of lubricants you can use with female condoms. How long does an IUD provide protection from pregnancy? So just to sort of capture very general, very basic knowledge on how to use the contraceptives. We asked her some questions about privacy, her perception of privacy, whether or not she was respectfully greeted, was she given an opportunity to ask questions, did the provider answer them? We also did the same sort of questions around interruption. Did they look at your health passport? Did they use any visual aids? Was there any sort of like explanation of the exams and procedures? And then also a little bit more, did the provider advocate a specific method for you? And then we also got into some more detailed information about whether or not the provider made any sort of, had any sort of negative interaction with the client, whether it was critical or judgmental comments, around the client's age, her preference for family planning, things like physical appearance, just sort of like judgmental comments around that. Yep, any sort of threats to break confidentiality, any requests for informal payments, did they yell at you or anything else you considered disrespectful or abusive? And then we also collected the same sort of respectful care questions around anything that happened post-consultation with any other health staff beside the provider that they saw. We pulled some questions around decision-making for your household or family. You're talking about who the main decision maker is around family planning, whether or not the woman could access family planning methods on her own if she wanted to. And then finally, we aim to capture client satisfaction questions through audio copy, where the woman, was supposed to be a little bit more private, so she doesn't have to tell the interviewer how satisfied she is with her services. She's given a brief orientation and training on how to listen to the audio questions, and then she selects the response herself on how satisfied she is or not satisfied at all, and then instructed on how to push next, so that the interviewer right then and there has no idea what data she's entering. All right, and I think that's it. So I will stop sharing this, take a couple of seconds to see if there's any questions as I flip over to our final slide.
Thanks to you, Elizabeth, for this overview. What's the difference between the client exit interview and the simulated client in the end?
Yeah, not very much in terms of the quality actions that you're collecting. The biggest difference, I think, is the fact that with the simulated clients is that they are trained on what specific things to look for. And yeah, and also a benefit of that is that if you do want to compare quality indicators across a large number of facilities, it is nice to have sort of a standardized case scenario that all of the providers will be presented with, so you can compare how they all respond to the exact same clients. Because of course, one thing about family planning is it's not a very strict algorithm. A lot of it depends on the client's preferences, what they want to use, their background, their fertility history, their desire for more children. So this just kind of standardizes it. And then also, of course, with the client, we collect satisfaction and knowledge, which is not something that we collected through the simulated clients since they were all previously trained.
I'd also add that the exit interview is done after the direct observation. So it's you can see what happened in the consultation, and then you're asking and you're noting it in the direct observation, and then you're asking the client to recall what has happened as well and how they were, whether they were satisfied, so you can pull those data together.
Yeah, thanks very much. All right, I'll go ahead and end and say, please visit the Google Documents to provide any detailed feedback. Again, feel free to leave comments, respond to others' feedbacks. Contact us if you would like to provide detailed feedback one-on-one. Shoot us an email. Would happy to set up a meeting by phone or by Zoom and get some more get some more of your thoughts on how these tools could be improved. We're very interested to know if you plan on using these tools and how you plan on to adopt them. And we are available. I'm going to say, I think through the Radar grant that we are available to provide feedback on your tools and on your plans based on our previous experience and provide technical assistance. That's something that we're certainly interested to discuss further. So I think I'll stop here. Does anyone else have any closing comments they want to make?
Thanks for joining us. We really value your input. So do jump onto those Google Docs and let us know.
Wonderful. Well, thank you, everybody, for taking the time to join us here for this session. It was a really good one. As was just mentioned, there are some email addresses up here. They'll also go in the email that I will send following this session for you to be able to share your thoughts. But feel free to reach out to any of us directly with any questions that you have. Otherwise, I look forward to seeing our JHU colleagues and many of you again next Monday for the session on ICCM and next Tuesday for the session on nutrition counseling. If you have anything that you want us to touch on or any feedback that you want to see incorporated into those sessions next week, just be sure to click on the link in the email that I send and send us that feedback, and we'll make sure to include it as well. So thank you everyone for joining us. Have a great rest of your Monday and a great week ahead. Take care.
Thank you.